Assalamu alaikum. I'm Dr. Mariam Fatma Vakar, and I welcome you all to the plenary session on hepatocellular carcinoma and its challenges in the developing countries. The session will provide an insight into the latest diagnostic and therapeutic strategies required in dealing with the cases of hepatocellular carcinoma. And I would like to welcome the facilitator of the session, Dr. Shehzad Riaz from Shifa International Hospital, Islamabad. And it gives me great pleasure to invite the chairs of the sessions, Professor Aman Nawaz Khan, who is a consultant diagnostic and interventional radiologist from Peshawar, Dr. Nand Lal, assistant professor of gastroenterology from LUMS, Hyderabad, Dr. Abdul Wahab Togar, uh, from head of the Department of Liver Transplant and Hepatobiliary Surgery from Gumbat, and also Dr. Faisal Dar, one of the leading transplant surgeons of Pakistan. Let's move on to the talks. I would like to welcome Dr. Asif Beg, who is a consultant gastroenterologist and transplant hepatologist, also one of the core members of the liver transplant team at Gumbat and has been involved in pre, peri, and post liver transplant management. And he's going to talk about the cost effective surveillance for HCC. Should it be continued lifelong? Please welcome Dr. Asif Beg. Sir, kindly unmute your mic.
Can everyone see my screen?
Yes.
Okay. So Bismillah Rahman Rahim. First of all, I'm thankful to Pakistan Society of Hepatology to give me a chance to present the topic of the first digital conference of Pakistan, cost-effective surveillance for HCC. Should it be continued lifelong? There is no conflict of interest for my talk. Okay,
yes,
the HCC, HCC, apology for those. HCC is the most frequent primary liver cancer, right? And HCC is the fourth leading cause of death worldwide and the third leading cause of cancer death worldwide. 5-year survival of liver cancer is only 18%. There are different causes of HCC which lead to the HCC. While hepatitis is the most common cause in Pakistan, while alcohol is commonest cause in West, the NASH is evolving. It will lead to the cirrhosis, early HCC, and the advanced HCC in the end. And the incidence is about 1.8% per year, and most of them they are untreated HCV, HPV. They are at the risk factors. Now, the very important question before proceeding to the other aspect of the talk: why is surveillance needed? Cancer surveillance aims to detect tumors at early stages, increase the opportunity to use curative treatments, and improve survival. Patients detected at an early stage are eligible for potential curative therapies like liver transplantation or surgical resection with more than 70% 5-year survival. If they are diagnosed late, advanced HCC left for palliative treatment and have a poor prognosis with median survival of about 1 to 2 years. What is effective surveillance? HCC risk must be high enough in the high risk population to justify the surveillance. Surveillance tests must accurately detect HCC at an early stage than it would otherwise present because of symptom, sign, or incidental imaging. Effective treatment which improve outcomes in screen detected HCC compared to treatment for non-screen detected HCC must be applied. Multiple types of harm should be considered when evaluating a cancer surveillance. There are different harms linked with HCC surveillance, like potential for physical harm, financial harm, and the psychological harm. Physical harms can result from surveillance or follow-up testing, extend beyond medical complication to include the discomfort. While the psychological harms can occur at any stage of the surveillance process include anticipation or fear of abnormal results, reactions of depression, anxiety, or cancer-specific worry after positive results, and psychological effect of being labeled with a diagnosis. What are different tools for surveillance? The most commonly used surveillance are the radiological imaging along with biomarkers. The commonest tool used worldwide is abdominal ultrasound, while the cross contrast enhanced ultrasound is another modality. Cross-sectional imaging like CT scan, MRI, and biomarkers are available. First of all, we will talk about the ultrasound. Every 6 month ultrasound is recommended for surveillance with or without measurements of alpha-fetoprotein. And the results of ultrasounds are operator dependent with a sensitivity of about 60 to 84% and a specificity of higher than 90%. But there are different disadvantages linked with this surveillance tool. Ultrasound, although its advantages of being being inexpensive and no risk of contrast or radiation. And there are so many several prospective and retrospective analysis are there for these tools, but their utility is low. Ultrasound is known to be operator dependent for us, and prior studies have suggest up to 1 in 5 ultrasound examination may be inadequate. This is evidenced by some studies. And what are different factors which are linked with the inadequacy of ultrasound? It includes the male sex, obesity and morbid obesity, alcohol or NASH, under recognition of small nodules, advanced liver disease, and the elevated AST and ALT. This is one study from the US, which is published in 2017, which showed about 20% of the time the ultrasound is inadequate. There are different, now coming to the studies regarding the surveillance, there are 2 RCTs are there for ultrasound which are performed 17 years back. Both are performed in Asia. Both are in the carriers of hepatitis B surface antigen. And in the study group is about, in first study in 2003, there are 3,000 patients, while in the other group is 9,000 patients. While in other study, 37% reduction is seen in the mortality in the screening group. While there are so many systemic reviews are available for the ultrasound-based surveillance, about 15,000 patients with cirrhosis are there in the 47 studies systemic review. And they have a pooled 3-year survival of about 50% who underwent surveillance. There are some odds ratio for their early tumor detection, curative treatment, and overall improved survival. The second, the most common biomarker used is alpha-fetoprotein, which is linked with ultrasound. Before going to the other radiological tools, I'm likely to mention here the alpha-fetoprotein. The most common serological test is alpha-fetoprotein, which is 60% sensitive and 80% specific. And it's linked to the tumor size, restricting its utility in detecting the small HCC. Increased AFE, the risk factor for HCC, and the several studies are obtained which showed the superior surveillance and diagnosis results by using combined surveillance method. The other biomarkers as well, like we have the DCP, PIFCA4, lectin-bound alpha-fetoprotein, glycogen-3, and Golgi proteins. Cross-sectional imaging, there are CT scan and MRI. There are 2 studies for CT scan and 2 studies for MRI surveillance are used in the literature. CT-based surveillance is also likely limited by the harms of radiation exposure and contrast-induced renal injury. This is the study in which they compared the ultrasound with CT scan, and interestingly, there's not so much. Ultrasound is marginally more sensitive and less costly than the CT scan compared for the annual screening. Sensitivity and specificity in summary for CT scan for any stage is about 87.5%, while specificity is 87.5%, same. While sensitivity for CT for early detection of tumor is much more, but only 62.5%. And again, this is the results of the HCC detection of the same study. MRI liver dynamic, there are 2 studies are there which evaluate MRI had a pool sensitivity of about 83% and specificity of 89%. But MRI is time consuming and costly. Prior cost effective analysis demonstrate MRI is not cost effective for HCC surveillance in all patients with cirrhosis. There's another short time MRI, which is an abbreviated MRI, shorter version to reduce in the scanner time, safe cost, more cost effective study. In the single study of 174 patient, it again had a similar sensitivity of 81% like MRI, but more specific. Future surveillance, mutation analysis of circulating tumor DNA in the context of liquid biopsy has emerged as a potential new tool for the early detection. It's a future surveillance. Now, what is the high-risk population in which this surveillance should be performed? All the major guidelines, all the major societies, EASL, SSLD, Japanese Society of Hepatology, APASL, they agree the surveillance should be performed in all patients with cirrhosis, whether it's size A and B, but they are and in non-cirrhotic in the spatial group, like if they are Asian females more than 50 years, Asian males more than 40 years, Africans more than 20 years, family history of HCC. This is an additional thing it's seen in the non-cirrhotic. This recall policy is important because sometimes we see a small nodule, it can be considered non-malignant and it can be kept close follow-up for 4-monthly follow-up. In the lesion beyond 2 centimeters on ultrasound, the CT scan should be performed. So if the lesion is between 1 to 2 centimeters and the imaging is indeterminate in both ultrasound and CT scan, then the biopsy should be performed. Now, what are the different society recommendation for the HCC surveillance? We have again the 3 very large society recommendation: APASL, SSLD, European Association of Study of Liver Disease, EASL. They agree ultrasound every 6 months. EASL and SSLD recommend with or without alpha-fetoprotein, while the APASL said every 6 months the ultrasound with AFE should be performed. And CT or MRI in those population of patients with a high likelihood of having the inadequate ultrasound or perform but inadequate ultrasound. ESMO, another association, again, all cirrhotics should be screened according to them, and surveillance in the spatial group, especially HBV carriers. Again, they recommend ultrasound every 6 months with or without AFP similar to the SSLD. NCCN, another cancer guideline, it recommends ultrasound plus minus AFE for the surveillance. Now, what is cost-effective surveillance? Most studies use decision model like Markov chain or decision trees model, which include the full economic evaluation of HCC screening programs, comparison between different HCC techniques for the HCC surveillance, outcome measures expressed in terms of quality adjusted life years. I'm just giving one of the example of one of the Markov model used in one of the Canadian study. They showed A, B, C, D, E. They divide into 7 groups with ultrasound and CT for diagnosis in group A, and B for ultrasound and MRI for diagnosis. And they found that the E strategy, which is a CT scan used for the surveillance, most cost effective when compliance was optimal, and G strategy, which is the surveillance with abbreviated MRI, is a conservative approach. Again, this is a summary diagram of how this cost is effective, this surveillance of this model. Sensitivity is about 59% of the CT based in this study, while the abbreviated MRI is about 71%. Now, in summary, surveillance lifelong requirement on the basis of clinical based surveillance program. Surveillance interval, if vary between 2 to 8 months, only 1.4% of tumor exceeded 3 centimeter. So a 6-month interval is more effective in terms of early detection and survival than a 12-month interval. Cirrhosis is a lifelong illness with potential risk of HCC. Surveillance should be continued lifelong. So in summary, this is a surveillance program, surveillance with ultrasound with or without AFP. If there's no nodule, it repeated in the 6 month with or without alpha-fetoprotein. This is according to the AASLD guideline. This is the second last slide. The population is the whole summary of my talk. The patient with cirrhosis, child ABC, and the patient on the waiting list for liver transplant, they should undergo the surveillance. Patient with HBV, if they have cirrhosis, family history of HCC, without cirrhosis, Asian males, and in patient with hepatitis C, the cirrhosis, non-SVR, post-SVR with bridging fibrosis, it will vary case by case, but the screening should be lifelong. The interval, it should be every 6 months. The commonest modality should be ultrasound and alpha-fetoprotein, while the contrast imaging CT and MRI are used in the case by case. In case of nodules, poor quality ultrasound, and elevated alpha-fetoprotein. So the take-home message of my talk: early diagnosis of HCC improves survival, but adherence to the screening program is suboptimal. International guidelines recommend screening patients with cirrhosis. Consensus on the screening patient without cirrhosis is lacking, but most of them, they are specified the HBV specific population. Lifelong screening with 6-monthly ultrasound in AFP cirrhotic and selected patient without cirrhosis. Thank you so much.
Thank you very much, Dr. Asif, for such an informative talk. Our next distinguished guest speaker is the President of Radiology Society of Pakistan and is currently working as an interventional radiologist in Lahore. He has been the former head of radiology department at Shaukat Khanum Hospital. He's going to discuss very early stage BCLC, HCC resection versus microwave ablation. Please welcome Dr. Najmuddin.
Thank you, Pakistan Society of Hepatology, for inviting me to talk about very early hepatocellular carcinoma treatment and review resection against ablation. I have no disclosures. Learning objectives of this talk would be to justify indications for resection and ablation as per guidelines, to critically assess related literature to date, and define a clinical algorithm to select patients between ablation and resection. Is ablation only for non-surgical patients in 2020? That's a big question, and I can reply to this by saying no, categorically. And we'll ask the happy liver brother here to define why I am so confident about this choice. So we've all worked with BCLC 2012 for a number of years, and the number one resection for stage 0 was always a resection. We've moved on, but before I go into the new guidelines, I would like to highlight that we are supposed to follow up lesions which are less than 1 centimeter in size with repeated ultrasounds at 4 months. Once they go beyond 10 millimeters, then multiphasic contrast enhanced CT or MRI is done. One of them is required for positively defining a typical lesion of HCC. If not, then you have to do a biopsy repeatedly in order to confirm the presence of HCC. So what does AASLD in 2018 add to the armament of treatment for stage 0 lesions? Given the level of evidence as 1, resection was kept at number 1 by AASLD and RFA microwave at number 2. It changed in 2018 at BCLC as well. The modified system or algorithm has highlighted ablation as the modality of choice even before resection for very early 0-stage tumors. We all know that the molecular data for such stage lesions less than 2 centimeter. Most of these lesions are de novo tumors. There is not much of a concern regarding liver dysfunction or intrahepatic dissemination, nor we are much worried about tumor biology as we would be at this stage when we have advanced disease. So what does a radiologist have in their armament to treat such lesions? We've been using radiofrequency ablation for years. It's pretty exhaustively used by people. Microwave has also been in the field for quite a long time. It's got an advantage that it reaches a higher temperature quite quickly and it's much more efficient in dissipating heat across the lesion. Cryoablation is used by limited number of interventional radiologists, given it's relatively cumbersome and difficult to use. Irreversible extrapolation is now being tried and tested in different trials for larger lesions more than 3 centimeters. Similarly, in surgery, things have changed. Surgery is the mainstay of ACC, given the best outcomes at 5 years up to 80%. But there is some concern regarding these patients. You have to assess multi-parametric composite assessment of liver function, take into account presence or absence of portal hypertension, and then extent of hepatectomy besides performance status and comorbidities in all these patients. But one thing is strongly recommended that peridissection mortality in cirrhotic patients should be less than 3%. So let's review why this zero-stage tumor is being offered ablation and kept at par with resection. Looking at this publication in Hepatology in 2010, a Markov model analysis was done comparing hepatic dissection versus radiofrequency ablation. And what the authors showed that there was no overall survival difference. And they also did a two-way sensitive analysis comparing the mortality associated with liver resection and local recurrence in the RFA group. And what this highlighted that the 3% increase in the local recurrence rate following RFA was comparable to 1% increase of perioperative mortality with regards to overall survival. And you can see how good the figure is for cost effectiveness and acceptability curves in such patients, particularly for less than 2 centimeters. This article published in Hepatology in 2013 prospectively reviewed 10 years of data and suggested that RFA provided similar life expectancy and quality adjusted life expectancy at a lower cost than a resection. However, the authors have highlighted that the early stage HCC should be surgically resected, and it remains the best strategy to adopt as a result of better survival rates at an acceptable increase in the cost. So what does EASL say about this? In patients with very early stage radiofrequency ablation in favorable locations, and I repeat, in favorable locations, can be adopted as first-line therapy even in surgical patients, and this strong recommendation. What about first-line RFA for patients less than 3 centimeters, but they are potentially transplantable patients? The cutoff line highlighted by Doyle in 2019 was 2 centimeters. He showed that there was a remarkable difference, in fact significant difference, in the overall survival of the two groups. 5-year survival was 79% in lesions which were less than 2 centimeters. So what about early stage A disease in patients where resection is not a possibility and they cannot have transplant? Ablation would remain the preferred choice. But we all know that BCLC stage A includes single HCC of any size, and I repeat, any size. So resection can be offered to a single HCC regardless of its size. For single larger than 3 centimeter resection, it is cost effective, but we need to be wary of the anatomic and non-anatomic resection variants and in order to reduce the recurrence rate. Another article published fairly recently in 2018 did a trial sequence analysis, a meta-analysis, and they highlighted that there was no difference in overall survival between the two modalities of treatment at 1 year, 3 years, though they did show that there was appreciable difference at 5 years. The other thing which the authors highlighted was that in order to properly randomize, as I said, assess the data sets, you require at least more than 10,000 of patients, 10,000 patients to be randomized for significant analysis. They concluded that complication rate clearly favored RFA more than HR. Another meta-analysis done recently reviewed more than 1,400 patients. They also showed no overall survival benefit across these randomized controlled trials. But when it came to less than 3 centimeter lesions, the tilt was more towards the ablative side. Another article which has been published in 2019 evaluated microwave ablation with hepatic resection. They also reviewed some data on metastases. Most of these articles came out from China or Japan, and they also, their primary target was LTR, assessment of LTR, and they showed that the recurrence rate was higher in the RFA group compared to the dissection group. But the secondary outcomes, they highlighted that there was no difference in overall survival between microwave and hepatic dissection, though the difference of DFS between the two modalities was obvious at 1, 3, and 5 years. A recent data in August 2020, a meta-analysis and review looked through again a lot of subsets up to 2018, and they concluded that majority of these patients had less blood loss, less volume of replacement fluids, and less number of transfusion required during surgery. But one thing was certain, that they also highlighted that the overall survival was better and the recurrence was more in the RFA group. The question is, are we still in need of randomized controlled trials for this stage tumors? Given the high number which I highlighted, it is not possible. It's not appropriate for us to randomize the majority of these patients to ablation if they are larger than 3 centimeters. And we know that these are two complementary modalities. However, we know that the central lesions amenable to ablation should be given priority to undergo microwave or RFA. Lesions like this are more amenable to minimally invasive surgery. They should be given an opportunity to be removed completely through laparoscopic surgery. However, RFA and microwave are now, the microwave in fact is changing the outline of our approach towards these patients, and we can do a kissing technique, the non-touch technique ablation of these nodules which are peripheral and subcapsular. So what are EASL guidelines telling us about it? Thermal ablation in a single 2 to 3 centimeter lesion in size is alternative to surgical resection based on technical factors, and that is basically the tumor location. Central lesions are more plausible for ablation, whereas hepatic and extrahepatic patient conditions are also would affect the outcome. So in JAMA in 2016, prognostic factors for post-operative liver decomposition were assessed based on portal hypertension, extension of hepatectomy, which is a surrogate for location and size of the tumor, and the MELD. They stratified the patients into low risk, intermediate risk, and high risk patients. If we use this formula and apply it to ablation for lesion size less than 3 centimeters, this is what would be the proposed algorithm. So patients without any portal hypertension with extension of hepatectomy to a minor level, MELD score would be a denominator. Anything which is less than 9 MELD score would be more suitable for resection, and more than 9 MELD would be more suitable for recombination. With the likelihood of a major extension, nodule size will be a denominator. So lesions which are less than 3 centimeters will be ablated, and the larger ones will be resected or treated with combination. In patients with portal hypertension, extension of a appendectomy with major risks, nodule size less than and more than 3 centimeter, we would decide between these two IR procedures done by the radiologist. And if minor resection, minor extension appendectomy is required, then ablation and a combination of minimal invasive surgery can be applied. So early stage tumors in this subset of group, which are transplantable patients. The author Moavi in 2018 reviewed the data set and showed no survival benefit. So liver transplantation is equally effective as a salvage therapy for patients with hepatocellular carcinoma recurrence following RFA or resection. So this is the salvage group in which most of these patients, well, clearly all these patients had RFA before they were transplanted at recurrence. The first-line ablation in potentially transplantable patients, again, going back to the data set which was shared by Doyle in 2019, lesions which are high risk, more than 2 centimeter, and have AFP levels of more than 100 are high-risk patients. If they are ablated, they need to be followed up very closely, and transplant should be done as soon as possible after the first hint of recurrence, because there is obvious survival difference between the two size lesions. So in a nutshell, so what does EASL say? Thermal ablation with radio frequency is the standard of care, and this is suitable for tumors who are not suitable for surgery. In patients with very early stage HCC, radiofrequency ablation is in favorable locations, can be adopted as first-line therapy, even in surgical patients. Microwave ablation and the multi-prong or multi-antenna probes which are coming out in the market will change the outlook about local control and survival, though at the moment the data is limited on this issue. So I hope I've been able to convince you that ablation is not limited for non-surgical patients in 2020, and ablation does have a role in this subset of patients.
Talk. Let's move on to the next talk. I would like to invite our honorable guest speaker, who is a renowned interventional radiologist and the Director of Radiology Department at Dow University of Health Sciences, OJA. He's also a member of the Faculty of Radiology, CPSP, and a life member of the Radiology Society of Pakistan. Please welcome Dr. Amjad Sattar. He will talk about the palliative treatment of a presented case with justifications and results, options of transarterial chemoembolization versus transarterial embolization.
Thank you, sir, for such an enlightening talk. Let's move on to the next talk. I would like to invite our honorable guest speaker, who is a renowned interventional radiologist and the Director of Radiology Department at Dow University of Health Sciences, OJA. He's also a member of the Faculty of Radiology, CPSP, and a life member of the Radiology Society of Pakistan. Please welcome Dr. Amjad Sattar. He will talk about the palliative treatment of a presented case with justifications and results, options of transarterial chemoembolization versus transarterial embolization.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Amjad Sattar, Associate Professor, Interventional Radiologist from Dow University of Health Sciences, Karachi. And I'm talking about the palliative treatment days for hepatocellular carcinoma. And the learning objectives of my talk are: what is TACE and what are its prerequisites before performing it, a brief review about RFA and microwave and cryoablation, and what is good palliation for HCC patients, and review of a few cases. The important requisites, as I want to discuss with you all, that before start to have treatment, we should have an appropriate pre-TACE CT scan with correct phases to identify arterial enhancement and delayed washout. The arterial phase usually taken at 35 to 45 seconds after the injection of the contrast agent, and the venous phase start at the time when it's 60 to 70 seconds already the contrast is given, and these are basically timed on the machine, and the trained technicians know how to handle these things. Again, the injection rate through a wide cannula with a power injector, always remember, is important. And before we do plan for TACE, we should also look for the portal vein patency, as if it is thrombosed, then the chances of treatment success are a bit low, and extrahepatic involvement should also be evaluated before we start to have a plan for TACE. Importance of time I am showing you is this, that at 18 seconds the basic enhancement is low in the liver parenchyma for the tumor area, and at 35 seconds it is quite nicely seen, and we can see there are multiple tumors there. So it's important that we should be taking the scan well in time, which is actually required internationally, so that we have a good generalization and visualization. Also the injection rate. So if it is 2.5 ml with a small bore cannula or slowly injected, then you cannot see a nice enhancement of the areas which are avidly seen when it's in a good quantity and required quantity, like 5 ml per second. The important prerequisites for the lab when you are sending the patient to interventional suite, and we consider it as hemoglobin not less than 9 and platelets count approximately up to 1 lakh is the basic need, because after femoral puncture the manual compression is usually better sealed off when the platelet count are good. And the LFT, in LFT the total bilirubin count is basically up to 2 milligram and not above it. Regarding PT and INR, the INR should be within 1.3 seconds range, and PT should be within normal limits, and if it is above, then we need fresh frozen plasma and also sometimes platelets when the platelets are low. Serum creatinine is important, as the contrast can cause nephrotoxicity, and sometimes in search of tumors and in long cases we need more contrast. And the blood sugar in cases of patient with diabetes should be within normal range or well within range, because at the site of puncture there are chances of infection, and post-TACE sometimes there are chances of abscess formation. The child A and early child B are usually good candidates to have better treatment. Like late child B and C usually are difficult to treat and usually not very helpful for the clinician when they send the patient for palliative treatment. So what is TACE and TAE? So TACE is basically transarterial chemoembolization with chemotherapeutic agent and in the vessel to embolize and thrombose and then packed with lipoidal. The transarterial embolization is without basic chemo, but embolization of the tumor supplying vessel is done, and few people say that it's equally effective as TACE if correctly and meticulously done. The other thing is TARE, transarterial radioembolization. These are basically yttrium or lipoidal containing spheres, which basically are used to embolize the vessels, but they are very costly in our area of world. So we usually not perform this in Pakistan, and the availability is also an issue for one or the other reason. So these are the material which we are using, like PVA particles, lipoidal, and microspheres with yttrium and drug-eluting microspheres. So the slurry is made, as you can see, in the lipoidal, mixed with lipoidal chemotherapeutic agent and also contrast. A few important features of conventional and drug-eluting beads-based TACE. Over here, their real-time fluoroscopy guided drug delivery in TACE is yes, and they're in DAB-based TACE. Sometimes it's difficult. Tumor labeling on CT prognostic value are yes, and on DAB base is not that good. Also, local release of anti-cancer drug is fast in TACE but low in DEB, and risk of liver infarct and bilioma are low in TACE and high in drug-eluting beads cases. Definitely, the cost is increased when drug-eluting beads are used, and it's approximately 30% in foreign setup, and more than that sometimes in our setup if they are available. The other things which we actually use for the treatment of hepatocellular carcinoma, although it's somewhat beyond my scope of presentation at the moment, but I just want to make you people clear that radiofrequency ablation is a good choice to perform, and this is basically causing heat injury and coagulative necrosis of the tissues, and usually below 5 centimeter up to 5 centimeter with no blood vessels more than 2 millimeter or approximately 2 millimeter in the vicinity are good cases for radiofrequency ablation. The microwave ablation consists of electromagnetic waves and can be performed by several routes, and most of the people are doing it percutaneously. Few are also doing intraoperatively or laparoscopically to target the tumor tissues. But the advantage of microwave ablation is definitely the time of coagulative necrosis and the temperature, high temperature need is quite effectively done in lesser time than RFA, because it takes much lesser time to ablate the area, because in microwave ablation the temperature is increased in quick time. Cryoablation people, most of the time they say that one added advantage in cryoablation, although most of the centers are doing above 2, and cryoablation is still in its infancy, at least in our part of the world, and people say that they also increase tumor suppressor cells once they are cryoablated. So these are the electrodes. The one on the left is basically sometimes 2 or 3 electrodes together are used, and these are basically cool tip needles, and the other one is a starburst type of the electrodes, which actually we open up when we go into the tumor according to its size, and then ablate with the RFA generator. In microwave ablation, just to give you some appearance of area of ablation, in conventional microwave ablation, it's a fusiform area. The pink one is basically the active zone which is ablated, and the passive zone is yellow shaded area. The red area is the smaller one, is basically the heat sink effect, and it is said that it is there also as in RFA, but relatively safer here. But still, the vessels more than 2 millimeter are really dangerous when they get ablated or coagulated. So more area of liver which is not required can be necrosed in that sense. So with newer generation microwave ablation generator, there is spherical area and not the fusiform area. So the chances of cutaneous skin burns and intercostal muscles or intercostal neurovascular bundle ablation or coagulation is lesser. Just to show you how the radiofrequency ablation has its effect, and the upper one are basically showing the enhancement of liver in pre-treatment liver, and C and D it is shown that after RFA ablation there is area of necrosis and no enhancement. In lower down 4 slides, there is a pre-treatment and post-treatment HCC treated with lipoidal with TACE. So you can see the deposition of lipoidal nicely covering all the tumor area, and there is no abnormal enhancing area left in rest of the liver, suggestive of total embolization with lipoidal. Also in HCC with polyvinyl alcohol treated with in TARE, transarterial radioembolization, and this is like you can see that there is area of necrosis and the tumor is ablated, embolized, and in massive HCC treated with sorafenib. In pre-treatment CT, you can see the area of enhancement and area of necrosis, and in post-treatment time, most of it is gone, but part of the area above and in the margins of the HCC are seen still enhancing, so the tumor is active, so there is residual disease. So what is good palliation in HCC patient? I was discussing one of the reason I'm just presenting. Palliative therapies aim to alleviate symptoms, improve the quality of life, and extend survival for such patients. And option of patient with HCC include surgical palliation, palliative chemotherapy, and TACE, and palliative radiotherapy to provide pain relief from bone and adrenal metastasis. So actually, these are basic modes of palliation and should be tailored according to the patient's need. At one time, we did a study regarding the health-related quality of life in patients undergoing transarterial embolization. And that study concluded that significant improvement in physical and mental health-related quality of life was observed in patients suffering from hepatocellular carcinoma after TACE. So it was done in 2014-15 at our center, and shows the good palliation. This was the form which we actually considered for the well-being of the patient. So another, we did a study, and it's going to be published soon. From 2018 to 2019, approximately 230 patients underwent TACE, and we found significant improvement of health-related quality after TACE when the lesion was less than 5 centimeter, when there are 2 or 3 lesions affecting single lobe, or in those cases where the portal vein was patent. So cases with thrombosed portal vein with cavernous transformation were also included, and they also showed better palliation, and definitely lesser than those who had patent portal vein. Also, stable Child-Pugh status after TACE, especially in Child-Pugh A, the palliation was good. And the study we performed while seeing the patient's lesions in CT scan and later on injection while we are doing the angiogram, hepatic angiogram before TACE. So there is a difference of size, and sometimes there are multiple lesions which actually we see on hepatic angiogram, which actually were not seen on CT sometimes. So in those cases where people think in long-standing chronic liver disease that there is only one lesion and they try to perform RFA, sometimes a few smaller lesions are left, and they later show up when we do the hepatic angiogram. So there is the importance of DSA scan definitely. So few cases you must be tired to see or waiting for cases. So this was my first case with good parameters, as I told you, and the age was 64 years old with HCV and chronic liver disease and child PUXA. Over here, the pre-test CT scan, according to all the requirement which we actually did for injection, there is enhancement in the arterial phase, which you can see on the right side top slide, and there is a delayed washout lower down, so it's hepatic tumor, basically malignant HCC, and this has to be planned for transarterial chemoembolization. The size is approximately 4 to 5 centimeter, and it's near the skin and major vessel. So basically, it was planned for TACE, and the TACE was done on the left. The blush of the tumor is seen, and on the right, a nice embolized area after injecting PVA was seen. The post-TACE CT scan shows a good patient response, and there is an area of necrosis and the whole area of enhancement gone. So for the time being, this is basically a settled patient. Case 2 is 61 years old female patient with hepatoma. All the labs were within range. Interestingly, most of the people rely on AFP values, and you can see that most of the cases which are being seen on CT scan triphasic have alpha-fetoprotein within normal range or just a few added or increased in number and not going in 3 figures or so. So in this patient was child PUX early B, and over here we can see that few areas of enhancement adjacent to the already necrotic larger area in the right lobe of the liver, and washout in delayed phases in the right lower slide. Plan for TACE was done, and then TACE was performed, and the other areas are gone, but part of this small enhancing area was left, and definitely it was a bit tricky, so it was left. And the other thing was that this might be after 6 weeks that this is child B, so there might be a bit of recurrence as well. In case 3, 55 years old male patient with child PUX early B again, with initially he had his lipoidal injected lesion first, and then came for retase because there is enhancement. You can see adjacent to it medial to the area of lipoidal injected liver, and there is a washout. So plan for retase was done, and as you can see, it was nicely embolized, and the post-TACE was better. So patient was having good palliation. And in case 4, now the 56 years old female patient with HCV and child PUXA. Over here, sometimes the disease is seem very simple, and there is area of enhancement and washout, and then we planned for TACE. We did the TACE, and it was nicely done. And this patient is basically recently done, and follow-up is awaited. The other case is 45 years old male patient with HCV and child PUX early B. So over here again, the early B disease with right lobe involvement and
be uploaded soon on the website. Our next guest speaker, I would like to welcome Dr. Abu Bakr Hafiz, who is a consultant hepatopancreatic, biliary and liver transplant surgeon at Shifa International Hospital, Islamabad. He received his training in complex surgical oncology department from Shaukat Khanum Cancer Hospital and abdominal transplant surgery from Georgetown University Hospital, USA. And he's going to discuss live donor liver transplantation for hepatocellular carcinoma, what to expect beyond traditional criteria.
Okay. Thank you very much. I would like to thank the organizing committee for their kind invitation. So the topic of my talk today is living donor liver transplantation for hepatocellular carcinoma. What to expect beyond the traditional transplant criteria. I have no declarations to make, and this is a brief outline of my talk. So I am going to be discussing a little bit about the traditional transplant criteria, what is acceptable post-transplant survival, expanded criteria for liver transplantation, implications of tumor dimensions versus biology, national perspective, and recently proposed algorithms. So we are well aware that this is the BCLC algorithm for hepatocellular carcinoma, and only patients who fulfill the early stage or the very early stage of hepatocellular carcinoma are eligible for potentially curative treatments. The potentially curative treatments include resection, liver transplantation, and ablative therapies. Liver transplantation overall is the most superior in terms of long-term outcomes, And the benefit with liver transplantation is that it removes a failing liver, it reduces the risk of cancer progression, it offers prolonged recurrence-free survival versus other treatments, and it also improves quality of life. So what are the traditional transplant criteria? So we are well familiar with the Milan criteria and the UCSF criteria for liver transplantation. These are the criteria that have been externally validated, and they're applied widespread. So basically, Milan criteria, you have a single tumor that is less than 5 centimeters in size, or you have up to three tumors that are not more than 3 centimeters in size. With UCSF criteria, you have a single tumor that is up to 6.5 centimeters in size, or up to 3 tumors, none of which is more than 4.5 centimeters in size. Both these criteria assume that there is no macrovascular portal invasion, there is no extrahepatic spread, and you can see that the 5-year recurrence rates are not that bad. They're actually less than 15%, and the 5-year survival is 70% more. But the question is, what is acceptable survival post-transplantation? Is it 100%? Well, as transplant surgeons and transplant physicians, we would all want our patients to survive for longer than 5 years and not have recurrence. But we know that sadly, that is not the case. And no matter how cautious we are with selecting our patients for transplantation, some of them are going to have recurrence. So what is acceptable? Is it 80%, 60%, 50%, 20%? So with the passage of time, the transplant community has actually come to this consensus that as long as the long-term recurrence-free survival is 50% or above, then probably we're doing okay. But when it comes to acceptable survival, there are certain factors that we have to look at. For example, what is the mode of transplantation? So with deceased donor liver transplantation, donor mortality is irrelevant because obviously the donors are deceased donors, but then there is competition at national or regional level for donor organs. Moreover, there is also competition with non-HCC patients who tend to have excellent long-term outcomes if they have a successful transplant. So if you are going to transplant somebody with hepatocellular carcinoma, you have to make sure that you've chosen your patient wisely, and they're likely to have comparable outcomes with non-HCC patients. On the other hand, when you look at the living donor liver transplant setting, the risk to a donor is probably the most important thing. There is a substantial risk of donor death, and we have to avoid it at all costs. But living donor is a personalized resource because the donor has to be legally or blood related to the recipient. So that is why this donor is not going to be donating his liver to anybody else, and it's a personalized resource. For the same reason, there's no competition with non-HCC patients to produce excellent long-term outcomes. That being said, post-transplant survival of 50% is very much acceptable in the setting of living donor liver transplantation. Another important factor is the funding resource. So if you are going to transplant somebody with hepatocellular carcinoma and the government is going to pay for that, then it is very important that we choose the best patients and those patients who are likely to have survival comparable to non-HCC patients. But if somebody is self-funded, then even if they fulfill the minimal acceptable criteria for transplantation, they can probably be offered liver transplantation, but it is very important that we clearly explain to them what are the expected outcomes and what are the likelihood of recurrence in the post-transplant period. And this is a list of expanded criteria for transplantation, and I'm not going to go through them, but the whole point is that worldwide transplant centers have pushed boundaries and they have transplanted patients who are beyond the traditional transplant criteria. And moreover, they've also produced recurrence-free survival, which is in excess of 50% at 5 years. These are also some of the other recently proposed criteria. And again, we have actually now gone beyond tumor size and number, and some of these criteria have included alpha-fetoprotein levels. Some of them have included DCP levels. Now you have response to local regional therapy, which can be used as a marker. And even patients' ECOG status has gained much attention in the recent case. So what is it about? Is it really the tumor dimensions, or it is the tumor biology, or is it an interaction between the two? So when we talk about tumor dimensions, we're talking about the tumor size, the tumor number, and the total tumor diameter. And the traditional transplant criteria have generally been based on these tumor dimensions. But in the recent years, we have seen that other factors like poor grade, microvascular invasion, alpha-fetoprotein levels, PIVKA2, which is also called DCP, response to local regional therapy, and findings on the PET scan have also gained widespread attention. And they're actually the surrogates for good or bad tumor biology. So this is from the UCSF group, and they actually looked at patients who were transplanted within Milan criteria. They had 211 patients, and they grouped them based on alpha-fetoprotein levels. And you can see that when the alpha-fetoprotein level was more than 1,000, the recurrence-free survival was poor. And they actually concluded that patients who have an alpha-fetoprotein of more than 1,000, they should not be transplanted, even if they are within Milan criteria. Later on, the same group showed that these patients can be considered for transplantation, provided that there is excellent response to local regional therapy and the alpha-fetoprotein reduces to below 500. Now, this is the Toronto criteria for transplantation, and actually it is one of my favorite ones because you can transplant any patient with any tumor size and any tumor number as long as there is no macrovascular invasion identified on preoperative imaging. Another important factor is that all those patients who were outside Milan criteria, they had to undergo a protocol preoperative biopsy, and those who had poor differentiation were excluded. So they showed that the 5-year disease-free survival was comparable to Milan criteria. So their patients had a 5-year survival of 66%, and those who fulfilled Milan criteria, they had a survival of 70%. But they also identified alpha-fetoprotein of 400 as an important prognostic factor. Recently, patients who have macrovascular invasion have also been transplanted. And although there are a number of studies that have shown reasonable outcomes, but I would just show you one here because this is a multi-center retrospective cohort study. It includes probably more than a dozen transplant centers across the US and Europe. And they included 30 patients with macrovascular portal vein invasion. All of them were downstaged, and then they underwent liver transplantation. And the authors actually showed a 5-year disease-free survival of more than 50%. Moreover, they also suggested that if the alpha-fetoprotein at the time of transplantation is less than 10, the recurrence rate is 11%, which is actually comparable to Milan criteria. So a little bit about our national perspective. So we have recently published our own data. In Shifa International now, we have done 948 living donor liver transplants. And between 2012 and 19, a total of 242 transplants were done for hepatocellular carcinoma. And in this study, these patients were included. So I'll just briefly go over the protocol that we've followed. So all those patients, obviously, who have extrahepatic metastases or main portal vein tumor thrombosis, they were excluded and they were not offered transplantation. But patients with tumor size greater than 10 centimeters, segmental or lobar portal vein tumor thrombosis, and alpha-fetoprotein more than 1,000 were offered local regional therapy. And the response to local regional therapy was used to determine whether they could be offered liver transplantation or not. The other patients were offered upfront liver transplantation. So we included 242 patients. The median tumor size was 2.8 centimeters, but it ranged from 0.1 to 11 centimeters. And the mean tumor number was 2, and it ranged from 1 to 15 tumors. So we had approximately 40% of our patients who were outside UCSF criteria. We had close to 20% patients who had more than 3 tumors, and 10% of our patients had an alpha-fetoprotein that was more than 600 nanograms per milliliter. And to summarize the results of our study, we found that if the alpha-fetoprotein was less than 600, irrespective of tumor size and number, the outcomes were generally acceptable. But if the alpha-fetoprotein was more than 600, then the outcomes were very poor. In particular, patients who had an alpha-fetoprotein of more than 600 and they had poor differentiation, they did not reach a 4-year recurrence-free survival. So we suggested that patients who have an alpha-fetoprotein greater than 600, they should undergo a preoperative biopsy to rule out poor differentiation. We consider this protocol to be slightly more efficient than Toronto criteria because based on this protocol, less than 10% of our patients would require a preoperative biopsy. But if we would follow the Toronto criteria, more than 40% of our patients would require a preoperative biopsy. So nevertheless, all of this actually goes on to show that tumor biology is actually becoming more and more important when it comes to selecting patients for transplantation. This is a recently proposed algorithm by the UCSF group, and again, they have used multiple biology-related cutoffs to determine what are optimal criteria for liver transplantation. So for example, alpha-fetoprotein at the time of liver transplantation, if it is less than 20, this patient is an optimal candidate for liver transplantation. But if it is more than 1,000, probably this patient should not have a liver transplant. In patients who have an alpha-fetoprotein greater than 1,000, if they can be downstaged and their alpha-fetoprotein comes down to less than 100, they are very good candidates for transplantation. But if their alpha-fetoprotein stays above 500, probably they should not be offered liver transplantation. And the same goes on for radiological response to local regional therapy, which is actually graded based on the RECIST score. And those patients who have complete or partial response to local regional therapy, they're actually very good candidates for liver transplantation. But those who have progressive disease should not be considered for liver transplantation. This is another algorithm, and from the left to the right of the screen, you can see that the risk of recurrence is increasing. So they have actually combined the BCLC stage with risk factors. And if you look at the risk factors, you can see that the risk factors are all biological. So there is microvascular invasion, there is poor differentiation, there is increased alpha-fetoprotein without decrease after therapy, PET scan findings, and others. So those patients who are in the early stages of BCLC and they do not have any risk factors, they can straight ahead proceed with liver transplantation, and the recurrence rate is going to be very low. Those patients who are in the early stage, but they have one risk factor, they can still proceed with liver transplantation, but the recurrence rate is going to be slightly higher. Now, those patients who are in the intermediate stage of BCLC, and they do not have risk factors, or they have just one risk factor, they can also be considered selectively for liver transplantation. But again, the risk of recurrence has to be explained to the patient. And the rest of the patients, they should not be considered for liver transplantation. So if there are two or more risk factors, or if there is advanced stage of BCLC, liver transplantation is oncologically futile. This brings me to the end of my talk. And in a nutshell, I would like to say that a living donor liver transplant candidacy has become increasingly reliant on tumor biology and less on tumor size and number. It is more individualistic and less generalized. So you can have patients with one poor prognostic factor, but multiple favorable prognostic factors, and he would still be a good candidate for liver transplantation. Long-term survival of 50% or more is acceptable in the setting of living donor liver transplantation. All patients who fulfill traditional criteria are not good candidates for transplantation. So somebody with a 3-centimeter tumor but an alpha-fetoprotein of 5,000 is not a good candidate for upfront liver transplantation. Macrovascular portal vein invasion is not an absolute contraindication to liver transplantation anymore. And patients with hepatocellular carcinoma, irrespective of tumor size and number, merit transplant evaluation in a transplant center. This is the list of my references that I've used for this talk, and thank you very much.
Let's move on to the last talk of the session. The guest whom I'm going to invite needs no introduction. He belongs to our foreign faculty and has been participating in the annual meetings of PSH previously. Please welcome Dr. Bilal Hamid, one of the leading gastroenterologists, expert in transplant hepatology from the University of California, San Francisco. He will be discussing the systemic therapy of hepatocellular carcinoma, present and future.
Assalamu alaikum everyone. My name is Dr. Bilal Hamid. I'm working as an associate professor at UCSF California Medical Center. My topic today is systemic therapy for hepatocellular cancer, present and future. I would like to thank PSH for the invitation and hope to see every one of you in person next year. The outline of my talk is to discuss about patients who will be candidate to need systemic treatment for hepatocellular cancer, first-line therapy for advanced HCC, options for patients who has progression on systemic treatment, and in the end, what are the side effects we all need to be aware about for systemic treatment. Before we go with the actual presentation, I would like to start with the case. We have a 56-year-old male with chronic hepatitis B with well-suppressed antiviral treatment. He was not getting regular hepatocellular cancer surveillance and had new lesions found on his ultrasound. He has well-compensated disease with normal examination. His labs have shown well-compensated disease with normal creatinine, bilirubin, INR, and his hepatitis B viral load is undetectable. Alpha-fetoprotein is 149. CT scan showed 2 hypervascular lesions, which were both LIRAD-5 in the right lobe, 7 centimeter and 4.5 centimeter. He has no evidence of metastases. Since he was outside the criteria, he was not considered for liver transplantation at this time. This is the CT scan showing 2 lesions in the right lobe. He underwent chemoembolization twice, but now has progressive disease with new portal vein tumor thrombus. So what do you recommend as the next step in this treatment of this patient who has progression of HCC on chemoembolization? Sorafenib, lenvatinib, regorafenib, immunotherapy with nivolumab, or combination of Y90 and sorafenib? So the correct answer is sorafenib. So this is, most of you are aware of the Barcelona stage, which has been used in management of patients with hepatocellular cancer. This is a modified from the ASLD about the management of HCC. Our focus today is to talk about advanced HCC, which we call stage C, which has progression of HCC on locoregional therapy with vascular invasion and metastases, and focusing on the systemic treatment. It is also important to know that countries like Pakistan, who has limited resources, whether we can follow the PCLC criteria completely. And I like this graph, which being used in determining whether how many resources you have in the country, whether it's limited, intermediate, and high. And when we talk about the advanced HCC, which is the topic today, there is also a question about what medications to use, as well as intermediate stage, where most of the time in countries where you have a lot of resources, we go with chemoembolization, arterial treatment, or radioembolization. But if you don't have these capacity, there are patients who can also be used sorafenib early on. And then again, in terminal stages, the best supportive care is important for most of these patients. The most important thing, which most of you are aware, is that it is a multidisciplinary player for hepatocellular cancer, which is absolutely essential. Having tumor boards where you have liver specialists, hepatobiliary surgeon, oncologist, radiologist, liver transplant program, and pathology working together to come up with a consensus. And I think that is an important part of it. I'm happy that in Pakistan, there are tumor boards, and now with the COVID world, the virtual tumor board can easily be achieved. It's not only that this is important for the care, there is data that if you use multidisciplinary care, you can improve hepatocellular cancer outcome. And so these are multiple studies have shown that having a tumor board helps with increased survival and patients getting better treatment for hepatocellular cancer. Now, before we talked about the actual study, the few concepts when we look at the systemic therapy or chemotherapy of HCC, which is important, or concept when we read the study, one is OS, which is overall survival. The second is PFS, which is progression-free survival. And the third term you will be here again and again is ORR, which is overall response rate. So when we look at the studies, we look at what is the overall survival on a treatment, what is the progression-free survival? Maybe the cancer is there, but there is no progression. And response rate is called ORR. And most of the time, we use this modified RECIST criteria on the scan to follow these patients on imaging to figure it out what is the response rate in these patients or what is the progression of these cancers. Now, sorafenib, which has been established as the first-line treatment for the care worldwide, is based on 2 studies. One is the SHARP trial. The SHARP trial, which was the first positive trial in hepatocellular cancer with advanced HCC, shows that the overall survival was 10.7 months versus 7.9 months in patients who were on placebo arm. There was another trial of sorafenib in Asia Pacific, where it also showed that the 6.5 months versus 4.2 months survival, and overall response rate was less than 5%. So based on these clinical trials, sorafenib was approved as the first medication, systemic treatment for hepatocellular cancer. So now I want you to go back to the case. So this is another patient, a 60-year-old female with hepatitis C cirrhosis who has been untreated. She has ascites, recurrent hepatic encephalopathy, whereas she's child C with high bilirubin of 5. Alpha-fetoprotein is 500. The MRI showed infiltrative hepatocellular cancer, which is 9 centimeter with invasion of portal vein, and there is no evidence of metastases. So what do you recommend in patients with that decompensated child C cirrhosis? Sorafenib, lenvatinib, chemoembolization, radioembolization, or supportive management and palliative care? So I agree with most of you, and hopefully you get the answer. In someone who has decompensated child C cirrhosis, who has all these complications, based on PCLC and any other criteria, it is the management is supportive and palliative care, as patient is not a candidate for any local regional therapy as well as systemic therapy. Now, we talked about the sorafenib, but it's very important to know that the liver function and sorafenib use. The sorafenib is extensively used in patients with Child's A cirrhosis, and most of the clinical trials include Child's A cirrhosis. If someone has Child's B cirrhosis, you need to use it caution because there's a narrow margin between the unknown side effect. There are some cohort studies which use Child's B as a part of it. But the sorafenib is still contraindicated in Child's C cirrhosis. There's limited life expectancy and low magnitude of benefit. There are certain studies that have been looking at it, but right now what the recommendation is that sorafenib is contraindicated with Child C cirrhosis. Now, from 2008 to 2017, we had no other medication besides sorafenib in someone who had progression of HCC. But now things have changed. This field of oncology has one of those most impressive new clinical trial, new medication from all over. And we'll talk about the first-line agent, which has been approved, as well as the second-line agent in patients who had progression on the first-line therapy one by one. So REFLECT trial was one of the important trials which has used lenvatinib versus sorafenib as the first-line treatment in patients with unresectable HCC. They have about 954 patients who were stratified, and these were mostly Child's A cirrhosis. They use about 8 milligram or 12 milligram of lenvatinib versus sorafenib, and the dose of sorafenib you need to know is 400 milligram twice a day. The primary outcome was overall survival, and the secondary outcome, as most of we talked about, is progression-free survival, quality of life, overall response rate. So if you look at the primary outcome, this is an inferiority study, meaning that there is the lenvatinib can prove as similar to sorafenib, and that was. So median overall survival was lenvatinib arm was 13.6 months versus 12.3 months in the sorafenib arm. And progression-free survival and overall response rate is actually, the overall response rate is better in lenvatinib versus sorafenib. So based on this criteria, the lenvatinib was approved in 2018 for the first-line treatment for hepatocellular cancer by US FDA. There were slightly more interruption in lenvatinib arm, but overall it was comparable, and therefore lenvatinib is the second option or for the first-line treatment for hepatocellular cancer. In the EASL guideline, it was suggested someone with portal vein thrombosis should not be used, but when we talk to our oncologists here, we've been using lenvatinib even with portal vein thrombosis. Now, this is the latest study which was just published this year, and this is called, it's a first combination treatment for the first-line treatment for hepatocellular cancer. So there were two arms for it, atezolizumab, which is checkpoint inhibitor, and bevacizumab, which is anti-VEGF medication versus sorafenib. This is from Roche clinical trial, Roche Pharmaceutical. What they use is locally advanced or metastatic or unresectable, again, Child's A cirrhosis, about 500 patients. Clinical endpoint was overall survival and progression-free survival. 1,200 milligram of atezolizumab and 15 milligram per kilogram every 3 weeks of bevacizumab. 336 patients in this arm versus sorafenib. It's 2-to-1 ratio of sorafenib of 400 milligram twice a day, 165. And patients were Child's B and C cirrhosis were excluded, as I mentioned. And this has a significant improvement. So if you look at the median overall survival, the hazard ratio was 0.58, which means that there's an improvement of 42% in the treatment arm of atezolizumab versus bev. And then you can see this overall survival. If you also look at the progression-free survival, it's what 6.8 months versus 4.3 months. And this data is, this analysis, which was published, is about 8 months data on the trial. Overall response rate by modified RECIST was also better, which is 33% versus 13% sorafenib, and complete response was also much better. So this, based on this, this medication combination is the first combination medication, number one, and number two is the first checkpoint inhibitor, which is atezolizumab, was approved as a first-line treatment for patients with advanced HCC. And when you talk to our oncologists, this will likely change the field in the future, and we are very much happy with this new development. Patients have better quality of life, or the what they call that no deterioration in quality of life, which we saw better. So these are better tolerated. The side effects were also similar, the grade 3 to 4 side effects in both arms. The important and the treatment discontinuation was also not very different. However, there were more hypertension, which we need to understand with any checkpoint inhibitor. Important point to note, in any patients with advanced HCC wanting to start these treatment, you need to make sure you have to evaluate them for varices, because that is an important part. GI bleeding rate was seen 7% in the combination arm versus sorafenib, and this was also seen in other historical data. So based on that, now the atezolizumab and bevacizumab is also being approved as a first-line treatment. So if you look at the landscape for advanced HCC at this time, in patients who have Charles A cirrhosis, good performance status, we can use combination, although most of the places sorafenib is still used as the first-line treatment. It is cheap and we have more data. But lenvatinib and this combination, atezolizumab versus bevacizumab, is also now the first-line treatment. Now, if you have a patient who use the first-line agent and you have progression, what are the options that are available in 2020? So these are the second-line agents, and which is regorafenib, nivolumab, pembrolizumab, and these are the other medication in combination of nivolumab. And one point to know that regorafenib is mostly for patients who have sorafenib tolerant, and the data on ramucirumab is it's better if your alpha-fetoprotein is greater than 400. Now, the overall survival in these patients with advanced HCC has significantly improved. And then we are seeing patients who are living 2-3 years even after advanced HCC, and this field is growing significantly, that we can see even better improvement in the future. Now, this was the RESOURCE trial, which is the phase 3 randomized controlled trial of regorafenib versus placebo in patients who have progression. So these are the second-line treatment, patients already on sorafenib had progression, and in the past, we didn't have anything to offer. So if you look at the study, regorafenib, the overall survival was better. This is a probability of survival, which was about 10.6 months in regorafenib arm versus 7.8, and then which was statistically significant. And based on that, patients who have progression on sorafenib, regorafenib was used as a second-line treatment. And this was approved by FDA and both European Society for second-line treatment, again, for Charles A cirrhosis who tolerated sorafenib. This overall survival difference was 2.8 months, and the main side effects were pretty similar to sorafenib. Patients who were Charles B cirrhosis, who have significant comorbidity and who did not tolerate it, sorafenib are not good candidate for regorafenib. There are other second-line advanced treatment, and I normally like to divide into different. The most important, we talked about tyrosine kinase inhibitor, which we already discussed about RESOURCE trial, which is regorafenib. Cabozantinib is the celestial study, which was shown that patients who had progression on sorafenib, this tyrosine kinase inhibitor based on this trial, again had improvement of overall survival, 10.2 versus 8 months. Now, the immunotherapy-wise, we have agents like nivolumab is the most commonly heard medication, which is available in Pakistan, although very expensive. So phase 2 checkmate clinical trial shows that the overall response rate was 19% and survival was 15.6 months. Pembrolizumab is again one of the other agent immunotherapy, which also have shown improvement in overall response rate and overall survival. And lastly, the anti-VEGF treatment, which is available as ramucirumab, and there was a phase 3 clinical trial in patients with alpha-fetoprotein of greater than 400, which shows benefit. So these are all the medications we have available, our second-line agent for advanced HCC. And some of these medications have also been studied for first-line agent, but none of these are approved right now for first-line agents. So now, based on the side effect, we need to understand the toxicity of targeted or immunotherapy. So targeted agents, in the first month, the common side effects that we worry about is arterial hypertension, diarrhea, and hand-foot syndrome. And these are the quality of life. It is pretty significant in these patients and need to be monitored. Once they tolerate the first month, you can see the rash and dry skin. And later in the course, we have seen cardiovascular event and thrombosis. So we all have to be aware of these medications. Luckily, in our centers, most of these medications have been monitored now by oncologists, and they have these nurses or symptom management clinic who work with these patients and adjust these medications. But I understand in Pakistan, most of these medications are managed by hepatologists, so you have to even pay more attention to side effects. The immunotherapy-related side effects which we see are rashes are one of those, and these immune-mediated adverse events. These are rare but very severe, and we have seen every kind of it: hypothyroidism, adrenal. The colitis and hepatitis are pretty severe, and we have to use sometimes very high dose of steroids and checkpoint inhibitor-related hepatitis and colitis. So you need to pay very close attention to these. One other thing in immunotherapy, patient and all these, if someone has hepatitis B or even patients who have been exposed or with core antibody, there is data about reactivation of hepatitis B. So you need to pay close attention to these patients. Now, for the summary of current advanced management of HCC right now, so patients who have progression PCLC-B with progression after taste or PCLC stage 3, Charles A with good ECOG performance status. In the past, we had only sorafenib. Then we had approval of lenvatinib, but the latest clinical trial, the latest approval now we have it atezolizumab and pertuzumab. So we have 3 choices, and again, sorafenib is still used as the first-line agent, but now we have 2 other possibilities. Now, patients who are either intolerant or progression on these agents, then we can use a second-line agent, regorafenib, cabozantinib, or there are other agents, including combination. And these boxes we're going to keep adding on. And so it is very important to understand that which patients are candidate for the second-line treatment and what are and in Pakistan, it's also important to know that when you consider second-line agent, what is the overall survival you're looking at? What would be the cost? So having a discussion with the patient and the family is the key. Understanding the side effects is also very important, but this field has been advancing significantly, and in the future, we may see patients who would be using all these medications and can be living for many, many years. So we have to make sure that we screen these patients, and when they're diagnosed with HCC, talking to them in the multidisciplinary clinic, in the tumor board, and making a plan is very important. So in conclusion, after 10 years, sorafenib is still the first-line standard of care for many patients with advanced HCC, but as we talked about, we have lenvatinib and the combination agent now present as an alternative first line. The multiple newer agent is approved for second-line treatment for advanced HCC. Survival for advanced HCC has now more than 24 months. And in the future, precision medicine may come into play in the treatment of advanced HCC. The cost and availability will remain a major barrier in many countries, including Pakistan. This is the end of my talk, and I hope that I would able to answer questions during this.
Thank you very much, Dr. Bilal, for such a brilliant talk. Now I would like to invite the chairs for their comments and questions from the speakers. Professor Aman Nawaz Khan and Dr. Abdul Wahab Dogar and Dr. Nandlal. Can you hear me, sir?
Yes, we can hear you.
Aman Nawaz could not join. He had got some family emergency, so he is regretted to join here as chairperson.
Okay.
First of all, can you hear me, sir?
Anyone else would like to comment?
Yes. Hello? Yes.
There are a lot of...
First of all...
There are a lot of questions in the chat box. Shall I begin with the questions? Okay. There is one question from the audience, that can nucleotide be given safely to patients diagnosed with hepatocellular carcinoma? I think I'll forward this question to Dr. Bilal.
Sorry, I missed that. What was the question again?
Can nucleotides be given safely to the patients diagnosed with hepatocellular carcinoma?
The nucleotide, are you talking about the hepatitis B medication? Yeah.
Yes, if he's suffering from hepatitis B.
Absolutely. There is nothing. Actually, patient, that is one of the things that, failure of hepatitis B is one of the reasons as we heard about in the talk for Polko and Stepan. So, but it is very important, especially in these patients who have HCC. If they have hepatitis B, you need to treat them. And at the same time, if you're using these medications, especially checkpoint inhibitor, you have risk of reactivation of hepatitis B. So they should be on treatment. It can be safely used. Thank you.
Okay, thank you, Dr. Bilal. Another question from the audience. They have asked to comment on the use of endoscopic ultrasound. Can it be adopted as a routine investigation for screening HCC, as it can avoid the radioactive contrast of CT scan, and also a better option than ultrasound, because ultrasound findings are more operator dependent? I'll forward this question.
I can probably answer this question. I don't think with the endoscopic ultrasound scan you can adequately visualize the whole liver. So the answer is no.
I think they were mentioning contrast enhanced ultrasound scan.
Okay. Thank you, Dr. Nadeem and Dr. Shehzad.
Dr. Mariam, this is Dr. Altaf Alam.
Yes, sir.
Most of the questions in the chat have already been answered by Dr. Shehzad Riaz and some of us.
Okay.
So I would request to take opinion of chairs, Dr. Nandlal, Dr. Wahab Dogar, and all the chairs, and then we can close this session because we have to move on to the next session as well.
Okay.
So we have Abdul Wahab Dogar, Dr. Shehzad Riaz, and Dr. Nandlal Serani. So if you have any comments to make, please go ahead.
Yes, sir. Thank you, sir. First of all, I congratulate the whole PSH team and kind invitation from Dr. Zishan and Faruqi sir. So I have a little question from Dr. Asif Beg, that what exactly level of AFP that correlate with the HCC, and is there any comparative study between AFP or base gamma peroxythrombin? And another my query is there any same protocol of HCC patient having liver transplant and followed by surveillance regarding HCC? So another my query is that if you found any regenerative nodules in the liver and the ultrasound, what will be the special recommendation for these patients? So these are questions from Dr. Asif Beg. And from Dr. Najam, I have a query that is MELD score is enough to decide about the section, or you go for HVPG? And from Dr. Amjad Sattar, I have a question that is there any separate indication of TACE and TAE? And you especially use the TACE in some patient and in some patient TAE. And I have a little question from Dr. Bilal Hamid Saab, that we have a lot of patients of the TACE. So do you recommend post-TACE sorafenib treatment, yes or not? If you can give the answer. Thank you.
A lot many questions to different speakers. Najam, are you there to answer this question, please?
I actually forgot the question. There's so many questions, one after another. So I forgot my question, in fact.
TACE versus embolization, bland embolization.
Oh, yes. Yeah, the jury is out, and I know everybody favors TACE using chemo, and again, nobody is certain as to which drug, apart from doxorubicin, is to be used, whether DC beads have to be used, what is preferred. Every center has its own logic. My logic obviously is more in support of a bland transarterial non-chemo embolization. And I can share a lot of meta-analysis and data with the shift towards bland management, chemo embolization. So I think it varies from person to person and center to center. But I personally am fully supportive of bland embolization.
Thank you.
Thank you.
Thank you. Thank you.
Dr. Alam, I can just quickly answer my question. Yeah. Sorry, just because I remembered the question before I forgot. So I think the most important, what I would again recommend, that all these patients with HCC should be discussed in multidisciplinary HCC tumor board. I think that is the key, where you have input from radiologists, interventional and surgeons and hepatologists, and in some cases oncologists. But I think going back to the, following the PCLC, and most of the tumor board try to do it, as Dr. Alam has mentioned in the past. So if someone is a candidate for local therapy, and, they should be getting it, and then a patient with advanced HCC or a progression on days should be candidate for. If there are resources issues or cost issues that patient cannot get chemoembolization, and patient or some other reason, in some cases in third world countries that we have recommended, just start sorafenib, but we don't recommend combination. There are some studies, especially with 990 and sorafenib. So the benefit of using combination is not, so far, has not been shown. Okay, thank you.
Thank you. Some brief comments from Dr. Shehzad Riaz and Wahab Dogar Sahab, please.
Yes. I personally enjoyed all of the talks. I've worked abroad and in Pakistan as well, and I could see the contrast, especially with regards to the cutoff for transplantation. I think we just have to understand that these are two different worlds. In the West, the livers are quite rationed, and therefore the criteria are very strict. But as Dr. Abu Bakr mentioned, that in Pakistan, sky is the limit, because basically it's a personal resource, and as long as the survival is 50%, at 5 years, we can push the boundaries.
Thank you, Wahab Sahab, Wahab Dogar.
Sir, I'm here. Thank you very much. I really enjoyed all the talk, especially Abu Bakr Hafiz, and I learned a lot. And thank you very much.
Thank you. Mariam, you may close the session now, because we have to move on to the next session. It's already very late. Thank you. If Mariam is not there, I thank all the speakers. Yeah.
Okay, I would like to thank all my honorable chairpersons, facilitator, Dr. Shehzad Riaz, and all the speakers, and especially PSH, for giving me the opportunity to moderate the session. And our next upcoming session is the state-of-the-art lectures by world's eminent speakers. So the audience is requested to stay online. Thank you.
Just a quick announcement for the organizing committee. We will be having a virtual closing ceremony tomorrow at 12:30, inshallah. So what I would request is the member of organizing committee meeting ID generate कर देंगे. Please do show up, और हम जब खाना खा रहे होंगे तो आप हमें सब देख सकेंगे. ठीक है जी? Thank you very much.